Hello, everybody. Welcome to the Clinical Edge webinar series. Today, I will be presenting. My name is Kathy Garrett. I am a clinical associate in the Behavioral Health and Wellness program and a senior research instructor in the School of Public Health. I'm delighted to have all of you here today. So today we're going to be talking about COVID-19 vaccine hesitancy. And in particular, we're going to be talking about strategies to help improve vaccine acceptance. So our objectives for today are to explore the general landscape, just get a feel for what's going on with vaccine hesitancy, both historically and at present pre-COVID, and also review COVID-19 specific issues relevant to vaccine decision-making that are likely to impact vaccine acceptance. We'll review evidence-based provider communication strategies to improve vaccine acceptance, and then we'll discuss actions and next steps to support providers in COVID-19 vaccine conversations to enhance vaccine acceptance. Just to give us a framework so we're all on the same page, according to the World Health Organization, vaccine hesitancy is the reluctance or refusal to vaccinate despite the availability of vaccines. So let's take a look at the general landscape of vaccine hesitancy. We know that the evidence of the benefits of immunization is overwhelming, right? Vaccination is one of the most successful and cost-effective interventions known to improve health outcomes. Vaccines have saved countless lives and improved health and well-being around the world. However, vaccines can only improve health and prevent deaths if they're used. I heard this quote yesterday, actually from a colleague. I'm not sure who first said it, but it's good. Vaccines don't save lives. Vaccinations save lives. So I think that that's really important for us to remember. That's really our goal, is to get people to take those vaccines that are there for us now, or will be by the end of December. So since the turn of the 21st century, vaccine hesitancy in the United States has been on the rise, especially among parents of children, but significant numbers of adults also refuse vaccines. And vaccine hesitancy is not a simple concept, it's quite complex. It's a complex public health problem, and it's influenced by many individual and systemic factors. In the next few slides, we'll examine those factors, and we'll go into that in greater detail. So let's start with the historical perspective. Vaccine hesitancy has literally been around ever since the invention of the vaccine, the first vaccine. In 1796, Dr. Edward Jenner discovered the first smallpox vaccine. He took material, they call it, from his milkmaid's fresh cowpox lesion. You know, cowpox was around at the same time as smallpox. However, it wasn't as deadly as smallpox. And he noticed that the milkmaids who were milking the cows who had cowpox were not getting smallpox. So he took this milkmaid's material, they call it, from her lesion, a cowpox lesion, and inoculated the son of his gardener, who was an 8-year-old boy. And he later exposed that boy to smallpox. And the young boy never did develop smallpox. His experiments were the first to test a vaccine, and they were met with, as you can imagine, they were met with a lot of skepticism. In fact, opposition to Jenner's vaccine was so intense among citizens that it led to the first mandated vaccination in England. If you want to read more about that, you can check out Calendar 2016, great overview of the history. So since that time, since the 1700s, compulsory vaccination has been strongly contested here and around the world. In England, enforcement of the first smallpox requirement disproportionately targeted working class and the poor. They were fined, they were jailed for non-compliance, and that provoked an organized opposition movement. And that movement led to reforms allowing for conscientious objections, and that was the forerunner then of contemporary exemptions from state vaccination requirements, which we still see today. In 1887, in the United States, the Anti-Vaccination Society of America was established, and it brought together like-minded members of diverse religious, ethnic, and socioeconomic groups. They were often joined by medical practitioners whose views were outside the mainstream of their professions. So this sounds familiar to us today. In 1905, the decision of the Supreme Court in Jacobson versus Massachusetts upheld the authority of governments to mandate vaccination. And vaccine hesitancy has existed all along. It emerged again in the 1970s with additional requirements for childhood vaccines. So here we see my take on a newspaper article. It was actually a real article. It was run in the York, Pennsylvania newspaper. And the headline in 1906, right after the vaccine was made available, it headlined with "Vaccination Stirs Revolt." So there were threats to burn down schoolhouses. They talked about whipping teachers. They talked about punishing school directors. And they just were not going to follow compulsory vaccination law. There were also reports of scuffles with the police over compulsory vaccination. And this kind of provides an important context when we think of the term resistance to vaccination. And we hear that term a lot today. So in the 21st century, vaccine hesitancy, as I mentioned before, has been on the rise. According to a recent review article, childhood vaccination rates in the United States are generally stable. That's good news. Rates of vaccine in children under 2 years old are on the rise, along with rates of exemptions based on personal beliefs. And pediatricians are also reporting increasing encounters with vaccine hesitant parents. And as noted earlier, adults also frequently hesitate or refuse vaccines. For example, according to the CDC, for the 2019-2020 seasonal flu period, among adults, only 43.5% of people got vaccines. That vaccination rate varied by race and ethnicity, with 51% of non-Hispanic white people getting the vaccine compared with only 44.7%, to the non-Hispanic Black population. So there's a big difference there. So what is driving this increase in vaccine hesitancy? Let's take a look at the individual and systematic factors. Some individual factors. The most common barriers by far to vaccination among vaccine hesitant parents have been well described in the literature. And most of those barriers are directly or indirectly centered on concerns about vaccine safety. Williams wrote a paper in 2014, and he reported that vaccine hesitant parents are not only more likely to have concerns about safety, but they're also more likely to believe that children receive too many vaccines, that their child may have a serious side effect from a vaccine, and that vaccines may negatively impact the child's immune system. Among the most persistent of safety concerns is worry about an increased risk of developing autism from certain vaccinations. For example, despite well-conducted epidemiological studies refuting any increased risk of developing autism following vaccination, some vaccine-hesitant parents still report this as a concern. Also, even though thimerosal is no longer used as a preservative for any recommended childhood vaccine, with the exception of the multi-dose influenza, some vaccine-hesitant parents still report concerns about mercury or thimerosal in vaccines. Another contributing factor is related to perceived risk versus benefit. During vaccine preventable disease outbreaks, vaccine rates tend to increase. So that's good news for us, right? For COVID right now. As the diseases come under control, though, vaccine rates tend to go down. And in this way, vaccines have been described as, let's say, victims of their own success. As rates of the original virus goes down, people begin to fear the vaccine more than the now unfamiliar disease. So they don't see the disease and they're no longer afraid of it because it has no meaning to them. And then people begin to focus on the vaccines themselves, and their concerns about safety go up. So finally, some people refuse vaccines based on religious or personal beliefs. I have to say that there's no religion that expressly forbids vaccination, but people do request religious exemptions to mandated school vaccines. And currently, there are about 45 states and Washington, D.C. that grant religious exemptions for people who have religious objections to immunizations. 15 states allow philosophical exemptions for those who object to immunizations because of personal or moral concerns and other beliefs. So let's talk a little about some of the systemic factors. These three factors that are listed on this slide were recently highlighted in the equitable allocation of COVID-19 vaccine consensus report of the National Academy of Sciences, Engineering, and Medicine. The authors highlight a really painful legacy of healthcare discrimination, medical research exploitation, and unconsented experimentation on African Americans, Latinx, American Indian, Alaska Native, and other marginalized communities. And the association between that discrimination and the widespread concern of phase 3 vaccine trials to enroll participants from these communities. This consensus report concludes that culturally tailored outreach and promotion campaigns will be essential to rebuild trust with these marginalized communities and ensure equity in vaccine availability and uptake. As noted earlier in this presentation, anti-vaccine campaigns have existed since about, as I said, 1905. However, in recent times, and I think most of us are aware of this, the anti-vax movement has become increasingly more sophisticated in its arguments and its ability to spread misinformation, especially as it relates to social media. For example, in a 2020 analysis, Johnson et al. Captured nearly 100 million people expressing views on vaccination on Facebook. And showed significant growth in anti-vaccine clusters, with anti-vaccination clusters being more likely to engage with undecided individuals. The authors concluded, based on their current trends, that anti-vaccination views will dominate in the next 10 years. And that's pretty scary. So this is where we are. Vaccine hesitancy has been listed among WHO's list of 10 threats to global health. 10 of the top threats to global health. Vaccine hesitancy is right up there. That was in 2019, before the pandemic. Let's talk a little about COVID-19 specific vaccine hesitancy. I've been looking at the literature and going through a lot of the recent surveys. There's a fast track on publications, and some publications are coming out even before they've been published. And what I've been seeing is that the recent surveys suggest that the willingness to accept a COVID-19 vaccine is hovering somewhere between 60 and 70%. I did see in one article that Colorado is pretty high, and that our willingness to accept is actually up around 75% or a little higher. So that's good news for us. Reasons for the COVID-19 vaccine hesitancy are varied. They include many of the concerns that I've already addressed. However, several factors are unique to the COVID-19 development process itself, and particularly how fast the vaccines have been developed. Understandably, some people are concerned about the impact of unprecedented rapid development and testing on safety, and the belief that the process is being driven by politics. Distrust in the government, along with medical research and pharmaceutical companies, are also common. So we have our hands full. There are lots of reasons why people are not getting vaccinated or are concerned about getting vaccinated for COVID. And we're really hard pressed to come up with ways to help improve vaccine acceptance. So let's talk a little about the evidence base for provider communications and strategies to increase vaccine acceptance. This is a model that is currently being used by the WHO. It's behavioral and social determinants of increasing vaccination. And at the heart of this model really is a focus on motivation, the readiness, willingness, and intention to vaccinate, as well as hesitancy. And as we can see in the picture on the screen here, that there are individual factors like what people think and feel, their perceived risk, their level of worry, confidence, trust, and overall safety concerns that come into play and affect motivation either positively or negatively. If people believe that they're at risk and they have confidence in the vaccine, then obviously their motivation is going to be higher. If they don't believe in the vaccine, if they think it's been rushed through too quickly, their motivation is likely to be lower. And it's the same with social processes. So we know, the literature strongly supports, that people really depend on their providers to help them understand vaccines and make their decisions about whether or not to get them. So provider recommendation is fundamental. It's really important. There's also social norms, gender norms, and equity, information sharing, and rumors. So if you have a provider who's making a strong recommendation, listening to your concerns and talking with you, that's a positive towards motivation. And if you're being strongly influenced by social media and your neighbors who are spreading misinformation about vaccines, that of course will affect motivation negatively. In addition to the psychological processes outlined here, there's also practical issues, vaccine availability, convenience, cost, service quality and satisfaction, incentives, those kinds of things. And we know intervention fatigue. So people get a lot of vaccines, and especially children get a lot of vaccines these days, and people just sometimes get tired. They don't want to have any more vaccines. So we have to be aware of the practical issues. Now, as far as the availability, convenience, and cost, we'll have to wait and see with COVID-19. They are saying, I have been hearing in news reports that it's going to be free to everybody, but I really, we don't know. We'll have to see how this rolls out. And we also don't know how available it's going to be for folks, particularly at the start. We know it's going to be used for people who are at the highest risk, and that would be the healthcare providers and the people who are first responders, and people who are essential workers have to be out there. So we have a lot that we just don't know in terms of the practical issues that will be confronting people. And then, of course, we have the vaccination itself. And if people are motivated, then we'd like to believe that they're going to come in, they're going to get the vaccine, they're going to accept and consent on the day it's offered, and they'll not be refusing and delaying. So one type of approach to vaccine conversations is the presumptive approach. And if you are a provider, you are likely aware of this, because more and more, this is the standard recommendation when offering vaccines, particularly to children. So a presumptive recommendation is just that. The doctor presumptively recommends the vaccination with a statement about the vaccines for which, in this case, I say a child is due because all of this research comes out of the pediatric environments. So here's an example. Mary is due for 3 shots today. Easy, simple, no additional information. This approach was first introduced by Doug Opel and his colleagues in 2013. It's also supported by other research. Neil Brewer, Ali Kemp have documented similar results. So this is a slide that shows the Opel study. This was an observational study, and Opel and colleagues examined the correlation between vaccination uptake and strength of provider recommendation. And as you can see in this diagram, 84% of vaccine recommendations were initiated by the physician. When the physician recommendation was presumptive, then vaccine acceptance was 74%, with only 26% of parents resisting. When the physician recommendation was participatory, on the other hand, acceptance was only 4%, with 83% resisting. So that was a pretty clear indication that the presumptive recommendation was more effective in this observational study than the participatory, which would just be asking people what they think of getting the vaccine. You know, basically, it would be like starting the conversation from a shared decision-making perspective, where you're inviting the person to share their point of view, and together you're going to come to a decision. So that would be the type of participatory approach that was part of this observational study. So this Opel's finding was supported in a randomized cluster study by Neil Brewer. And they reported significant increase. This was for HPV. They supported a significant increase in HPV vaccine uptake in patients of providers who were trained to use that presumptive recommendation as compared to a participatory approach. So the intervention group in that study demonstrated a 5% increase in vaccine uptake when compared to the control group. Another approach that is very promising is motivational interviewing. And for those of you who are not familiar, motivational interviewing is a client-centered directive method for enhancing a person's own motivation to change, their intrinsic motivation. And we do that by exploring and resolving ambivalence. So ambivalence in the context of COVID-19 vaccine would actually be a hesitancy. We're going to help to resolve hesitancy. The last line here is key to successfully using this approach, because motivational interviewing is really a way of being rather than a way of doing. The focus of MI is to enhance motivation. It's not about taking action. And while action is the desired outcome, we do want parents to accept a vaccine. It can't be the focus of the conversation. People need to prepare themselves to take action. And, you know, we live in an action-oriented society. It's easy to skip over, a preparation to change into a behavior. And it's for this reason that many people fail in their movement towards their goals. And it's for this reason that many people do not move through their hesitancy and do not ultimately accept vaccines. So motivational interviewing is a way to meet people where they are, to not argue with them or try to persuade them to do something that they're not ready to do. So just basically, like MI has a skill set, it also has a heart set. And that includes partnership. So individuals work together, the doctor and the patient work together. In this method, a provider of MI would explore rather than telling people what they have to do, demonstrate interest and support rather than persuasion or argument. And Bill Miller, who brought us MI, always says that MI should be more like dancing and less like wrestling. Acceptance, so we don't want to put a judgment on people for getting a vaccine or not getting a vaccine. We recognize the inherent worth of every human. So if we're in an MI spirit, we are not going to, dismiss people from a practice if they don't get a vaccine, as some providers do. And compassion. It requires an active promotion of the welfare of individual being and the patient or the parent's needs in the case of children getting vaccines are the priority. And finally, evocation, the discovery of and the focus on individual strengths and resources. So each person possesses wisdom and experience that guides their actions and can facilitate positive change. And so the role of the provider is to draw out this knowledge by being interested and curious in the patient's perspective. So the primary goal of MI is to increase someone's motivation to change. And remember in that chart, in that model I showed you before, motivation is the key in the center of the psychological process of vaccine decision-making. So what do we know about vaccine MI and vaccine acceptance? I have to be honest with you, there is a huge literature out there, numerous articles defining vaccine hesitancy and its determinants. But the empirical evidence for effective strategies like MI to improve vaccine acceptance, it's lagging a bit behind. Despite that, MI has shown promise in its potential to improve vaccine acceptance. And I'm going to tell you about two studies with positive results. So the first is a recent cluster randomized trial. This was conducted by our colleagues right here at the University of Colorado, Amanda Dempsey and Sean O'Leary. And that included motivational interviewing as a part of a broader multimodal communication project. And it was shown to be effective. There was an increase in uptake of HPV vaccine among the hesitant parents. The study actually reported a 9.5 absolute percentage point increase in HPV vaccine and a 4.4 absolute percentage point increase in HPV vaccine series completion in intervention practices. So I was a collaborator on this study. I was the MI lead, and I had the pleasure of training the intervention practice providers. And during the process evaluation, the providers reported that the MI training and the tailored fact sheets were actually the most useful information, the most useful components for them. So there was an outcomes paper published on that, and Amanda Dempsey is the lead author. And then there was another study, a Canadian study, and that was done by Greg Muir and colleagues. And they published in 2019, they looked at motivational interviewing with parents who received only one individual motivational interviewing intervention. This wasn't a randomized cluster study. This was a controlled pre-post intervention study that was nested within a randomized controlled trial. And the authors reported that compared with pre-intervention status, participants who received the MI-based intervention displayed lower hesitancy and greater intention to vaccinate. That was for infants 2 months of age. There's also ongoing research. So Doug Opel is working with Sean O'Leary. They're co-principal investigators right now on a study testing the presumptive recommendation with motivational interviewing. It's called Pivot. I'm also a part of that study, and it's still in the field. So we don't have published results, but if you're interested, you can read a new publication that just came out, I think it like this week or something like that, that describes the intervention. And also Sarah Brewer here in the university is doing an implementation study that's looking at motivational interviewing, similar to the work that Sean O'Leary has done in other populations, but she's looking at mothers, pregnant women, and vaccines, maternal vaccines. So that's pretty important too. And you might want to check out, there's also a new publication available on that. So we do have some evidence, and that's, these two approaches are have the best evidence of anything that's out there. And as I said, the literature is small. There's not a whole lot. So where are we going? What are we going to do with the information we have? We have to do something because things are moving really quickly, and vaccines are going to be available to us probably by the end of December. So we're going to be called upon, I think, to work with the speed of Operation Warp Speed. We need Operation Warp Speed for vaccine hesitance, just like we have for the development of the vaccines themselves. There's research underway to identify general attitudes and trends and barriers specific to COVID-19 uptake. And as I said, the literature is just rapidly expanding. I can't believe the number of articles I see every day. And the behavioral health and wellness staff, we've been actively monitoring the literature and cataloging it so that we're able to tap into the latest findings. And the literature on effective communication strategies to improve vaccine uptake, like I said, it's slim. But we do know that the presumptive communication approach and motivational interviewing in the context of childhood and adolescent vaccines are growing. So in collaboration with the Unity Foundation and Indiana University, quite recently, the Behavioral Health and Wellness Program has developed a motivational interviewing video series for providers, and that's for adolescent vaccinations. And we're hoping to use the video work that we've done as a template for COVID-19 vaccine conversations, at least in terms of how we blend the presumptive recommendation and motivational interviewing. So what are we going to do? We've got funding from the CDPHE, and we'll soon be developing a communication and training to assist healthcare providers in reaching and effectively communicating with patients to maximize uptake of the COVID-19 vaccine. Over the next 6 months, the Behavioral Health and Wellness Program will conduct a qualitative study of COVID-19 concerns, barriers, and motivations among priority populations. The study will include a series of focus groups with at-risk populations who self-identify as vaccine hesitant. And included in those populations will have behavioral health, low income. That'll include homeless and at risk for homelessness, young adults, elderly, LGBTQ, and communities of color. Most importantly, African American and Latinx. The focus group discussions we plan to cover perceptions of vaccines, both the pros and the cons, barriers to vaccine acceptance, facilitators to vaccine acceptance. We'll explore the role of healthcare providers in guiding patient choices. We know that for parents of children, healthcare providers are the most important, most respected source of information. We do not know if that will be the case with COVID-19. effective messaging to address vaccine hesitancy. And we want to find out more about health neighborhood hubs of care to increase vaccine promotion of vaccines within these communities. In addition to that, we'll be conducting key informant interviews with experts, including state vaccine hesitancy experts, national vaccine hesitancy experts, and motivational interviewing experts. We'll take the data from the focus groups and key informant interviews and analyze it, and that will be summarized in a report to the CDPHE. And results of the studies will inform then the development of our training videos. And based on our analysis and previous experience, the Behavioral Health and Wellness team will develop provider-patient training videos to assist providers in vaccine hesitancy conversations. And this video training program will be implemented throughout the state of Colorado. So talking about the videos specifically, they will include messages tailored to concerns of at-risk groups. They will have presumptive guidance in terms of vaccine recommendation at the healthcare visit. And they'll also include motivational interviewing and other communication strategies to address vaccine hesitancy. So I've included references at the end of the slides, and if anybody would like a copy of those references, I could get them to you. And at this time, I think I will open it up for questions.
Hi, Kathy. Thank you so much. That was deeply informative. I learned quite a bit myself. So we do have one request. There was a link on a slide like 3 slides ago. I think it was on the, it was the slide before what's next, maybe where we're going. And we've had a request for that link. And Jody has asked, do you expect CDPHE to make COVID-19 vaccination mandatory for healthcare workers, similar as they do to the flu vaccine?
I don't know for sure, but I would think that they would. I mean, if they make it mandatory for the flu vaccine, I think they would likely make it mandatory for COVID-19 as well.
We've had 2 different people ask whether or not they'll be able to access recordings or PowerPoints, and they typically, and somebody on the line can correct me if I'm wrong, but we have made these Clinical Edge series webinars, the archived version, the recording of it, available on our website. And normally on the same page we build for the video, we will also provide a link to the PDF of the slide deck. Kathy, do you know if we're not providing the slide deck for this one?
I have no reason to assume that we're not going to provide it if that's what we always do.
Okay, great. So yes, so I think that we'll send a follow-up email to those of you who were in attendance today. You'll get a thank you for being here, and also, by the way, thank you for being here. You'll get a note to that effect, and then also a link to wherever the webinars and materials are archived. And Chad is wondering if you can give a couple of examples of how a provider might start a conversation with a patient who is vaccine hesitant.
Well, if we follow that's a great question, Chad. If we follow the presumptive recommendation, then we would start it presumptively with, we have the vaccine, we have the COVID vaccine here today. I strongly recommend that you get it. Something like that, without asking them if they want to or they don't want to. And then what the provider would do is listen to the response. And if the response is, yeah, great, yeah, I want it, great, then go ahead, just vaccinate. Sometimes people are ready to go and we don't want to, we just want to get right to it. Sometimes people have questions, but they're not really hesitant. They're just genuinely curious about the vaccine, and they just want to be sure about safety and effectiveness and that sort of thing. So what the provider would do then is to just answer the questions honestly. And then, ask the person if they're ready to get the vaccine after that. If people are hesitant, then the provider will hear that because the person will say, no, I'm not getting it, or I don't think I'm going to get it today, or I'm really afraid of it, or something that indicates that there is hesitancy there. And at that point, the provider would pivot to MI. So they'd come out of that presumptive position, and then they would start being curious and asking the person just what it is they're concerned about and trying to understand it from the person's perspective.
Great.
So we start presumptive and then we pivot.
I'm going to sort of go with a follow-up to that I'm just creating on the spot. Kathy, do you know if there's been any research on sort of the passive approach where like there might be posters or brochures that are visible to the patient that sort of invite that initial discussion? And if so, like what, I know that it shows up in other parts of healthcare. I wasn't sure if it showed up in this vaccine literature.
Yeah, it does. Absolutely. I mean, I'm not totally familiar with that whole literature myself, but I do know that I have seen articles that address that. And I know from my training in pediatric practices that those types of posters and that kind of information is all around the doctor's office and has been used. And I think in Sean O'Leary's study, they didn't have posters, but they had like a little interactive program that people could use to learn more about vaccines that they could watch in the waiting room before they went in.
Great, thank you. Ivy has asked, I've read a few articles that state that frontline healthcare workers would be among the first to get the COVID vaccine. Is this congruent with with your research and what you believe will happen with the COVID vaccine?
Yes, absolutely. I think the healthcare, that's everywhere I look, that's what I'm seeing. And the World Health Organization did put together, a guideline for getting the vaccines out. And everywhere I look, it says that healthcare workers will be first in line.
And then, I'm going to ask another follow-up to that. What does the research say about vaccine hesitancy among those frontline healthcare workers? Is that something to worry about there too?
I haven't seen it. I haven't seen anything on yet. I mean, that doesn't mean it's not there, but sure. I haven't come across it. Good, but I'll take a look now for sure.
It just occurred to me that if we're all preparing to talk people through vaccine hesitancy, the first people who get it might be the first people we need to think about. Jesse has asked, lately I've had a lot of patients come with the reasoning, quote, vaccines are a multi-billion-dollar industry, end quote. So how do you respond to this version of vaccine hesitancy when it does not specifically include any medical reasons?
Well, I would say that we would want to respond to a person who's bringing up that issue by recognizing their concern, validating that. And then the message that we'd want to give is that this was a strong collaborative effort between the government and pharmaceutical companies to get out a vaccine and save lives as quickly as possible. Vaccines typically are not huge money makers for pharmaceutical companies. It's not where they're making all their money. And so that would not, for me, that would not be a concern. I'd want to point that out. And I'd also want to point out that that the vaccines are safe, and hopefully we will have all of the supporting information to make that claim, to do that. So I think the bottom line is that pharmaceutical companies are not going to get rich off of these vaccines, not from individual patients, that's for sure. And it's likely to be free. At least that's what they're saying, that everybody in America who wants one will get one for free. Now, we heard that with testing too, and I don't think it rolled out quite that smoothly, but that's what they're saying. So we just want to build confidence, but always first recognizing that we understand the concern.
Yeah, okay, thank you. And then we also have the question, are there any specific concerns, that is to say, concerns specifically about the COVID-19 vaccine that may make people hesitant, including potential side effects to that vaccine?
Well, I've been hearing that each vaccine will be different, and we don't have all the information. I just saw when Moderna came out with their report that the vaccine was 95% effective. I did not see their side effects, but I looked at the protocol. I looked at information from the Pfizer study, and I did learn that there are some side effects that are relatively, they're not significant when you compare the side effects to COVID. But there was a recommendation made that when healthcare workers get the vaccine, they should be prepared, and their organizations, hospitals, practices should support them in taking some time off, maybe a day off, because the side effects are flu-like symptoms, high fever, body aches, typical symptoms of a flu or a mild case of COVID. And so they may not be able to go to work. Also, there's a concern about 2 shots, because you're going to get one and then you're going to get it 3 weeks later.
Oh, that's a good point. There, on the one hand, we have this concern about side effects, and then we also have this concern of whether or not you're going to be able to appropriately time your own visit back to get the second one. And
That's exactly right. That's exactly right. You have to come back in 3 weeks. Some people reported more side effects on the second shot than the first, and vice versa. So it's not an easy shot. It's not like the flu shot in that regard.
I have so many follow-ups on my own, but Mary has raised her hand. I'm gonna, Mary, I have theoretically unmuted your line if you'd like to go ahead and ask your question. Unless that raise your hand was on accident. And now the hand is gone, so I'll just assume that she's remuted. Okay, so sorry to call you out there, Mary. If anybody else wants to raise your hand and ask your question live. Otherwise, we're within about 12 minutes or so. I hate to keep putting you on the spot, Kathy, but this question about the potential ulterior motives of the vaccine, the pharmaceutical companies. I understand that if I misquote or if I say the wrong intent for you here, Jesse, let me know. But I think that there's this issue of medical trust.
Yes.
At stake here. And so it's not a medical issue in the sense that we're not worried about headache, fever, chills that may be as a potential tiny side effect, but it is a type of lack of trust that is specific to the medical industry. And we handle that with other kinds of vaccine hesitancy. We African-American communities are a little bit more reluctant to sign up for the flu shot because of, historical trauma and those sorts of things. So I don't want to sidetrack that question too much, because I know it changes the intent a little bit, but are there specific strategies to deal with medical distrust when the person giving the advice is a doctor? Yeah,
it's a great question. I think there's going to be mistrust there. It's already there, and it's growing, just based on the way this vaccine has been developed and rolled out so quickly without, vaccine trials typically take many, many years. And when a provider says, this is good for you, people trust their providers, particularly parents of children, very much trust their providers, and that works well. In this case, and this is me speaking, and from what I've read and seen, I think it's going to take a whole lot of community involvement. People who are respected in the community coming out and saying that they're getting the vaccine themselves, that they support it, really talking within people in the churches and in community centers, all of the key stakeholders being out front and helping with that message. I also saw this morning that Congressman from Montana came out and shared that he had participated in the vaccine trial and wanted to tell his constituents that he made it through, The side effects were tolerable. It's really important. He supports it. And I think it's going to have to be more than the providers in this case. And I'm not even sure, I don't know, perhaps other people on this webinar know, but I'm not even sure that that all the vaccines are going to be given in the doctor's office. You know, the research I was talking about is research with parents of children. So all of that is happening in the provider's office, but they're going to be rolling this out and wanting to get it to people, I imagine, in multiple ways. So I think there might be other people besides providers, and we might learn more about that in our focus groups.
I do know that from conversations I've been having at the Skaggs School of Pharmacy here on campus, that they're preparing the different types of pharmacists for rollout as well, including what they might have to do regarding refrigeration in the retail site. So,
oh my goodness, yeah.
Potentially deep penetration into communities, even if it's still medically adjacent. We do have a question from Trisha, and she says, how would you recommend responding to people who truly believe in like the deep conspiracy theories, the microchips in the vaccines, that kind of thing?
Yeah, well, we're not going to change those. I mean, there's no real intervention that is going to change their minds. So those hard and fast refusers generally don't respond to any kind of conversation, MI, presumptive, any of it. So we generally go to autonomy support. So just recognizing that it's their choice and it's their decision. Asking permission to share your view on it if they're open, which they may or may not be. And then leaving, just not arguing with them or persuading them or causing them to not come back and have a conversation with you again. So our goal at that point is to keep people coming back. We're not likely. We don't want to spend a whole lot of time trying to convince someone of something they are not going to hear. We're really focused more on the vast majority of people who are just genuinely hesitant.
I was going to ask a follow-up to the earlier conversation about the medical trust, distrust, along with that advice coming from the provider. And I don't know if it maybe conflicts with what I presume will be your answer for that question, if it conflicts with what you just said. So it's worth asking. Since the healthcare workers are going to get that vaccine first, and of course, theoretically, those are the people who are going to be giving the advice for others to vaccinate. And you've already mentioned this a little bit with the congressman. How powerful is it to say for the doctor to say, I already have it, I took it and I'm fine, I was fine. And maybe it plays differently with the conspiracy theorists on the waiting room. But generally speaking, is that a good strategy for providers?
Absolutely, absolutely. The literature does suggest that when providers are honest about themselves and again in the area of childhood vaccinations, sharing that they got the vaccines, like a HPV vaccine for their kids, parents really appreciate that, and that is an intervention in and of itself. Excellent. Thanks for that, Jim.
And then Cindy Flowers asked, any studies done if a patient is asymptomatic, positive COVID-19, so they're asymptomatic positive, having difficulty with the vaccine while positive unknowingly? Any studies done? I'm not sure that I'm reading what you wrote there, Cindy, but I'm not sure that I'm reading it with the right inflection. Can you either clarify that for me or raise your hand and I'll unmute your line? Any studies done if a patient is asymptomatic positive?
Asymptomatic positive.
Having any difficulty with the vaccine while positive. So I'm going to try to restate. If they're positive and they don't know it, and they get the vaccine anyway. So maybe you're thinking that maybe they're doubling up.
Oh yeah, I have no idea. I have not seen anything on that in the literature yet. I would
think just given the way that phase 3s work, it would be almost impossible because they're getting regular tests to identify the illness as rapidly as they possibly can. So they're definitely negative when they get the vaccine as of now.
Yeah.
And then, of course, as soon as they become positive, we'll assume they're either in the placebo trial or they're one of the other cases where they don't. So I'd say that right now we probably can't have that information. We
don't have that information, but it is a great question, and it is probably going to be a big concern, because when people come in for their well visit or whatever they're coming in to see the doctor for, or even if they come in because they just want to get the vaccine.
Right.
So they make an appointment. They're not going to know if they're asymptomatic. So will they test people who come in for the vaccine? I'm not sure. But yeah.
So we're about 4 minutes to time. I'm going to go ahead and ask another question while we wait for others to raise their hand or chat in a question. And that is, to what extent can the provider utilize the strategy of bringing in other family members into the conversation or advising people to go back to friends or family for more advice?
Oh, I think that's a given. They should definitely be doing that. Just spreading the word, inviting people to tell others, and encouraging them to share their own experience when they talk to others. I mean, we're not going to be able to dance around the side effects. We just have to be honest and frame it that if you're having these side effects, you don't have the illness, and that's a good sign your immune system is working. And stay focused on the positive.
Now, at least 2 of the vaccines that are coming out, and just eschewing the brands because I've actually forgotten what the second one is. These are mRNA vaccines, and so they're not actually getting whole virus, dead or alive.
No, they're not.
But are the side effects? We're still asking the body for an inflammatory response.
Right,
right. Kind of side effects we're talking about.
The body responds to as if it were COVID, even though it's not. And so when it activates the immune response, it's similar to the kind of symptoms you have when you have COVID, but much more mild. So I haven't heard of anybody having any adverse.
So one of the things I've been following a little bit more closely is the association with first incident mental health diagnosis after a COVID diagnosis. And there's assumption here that potentially COVID is causing the mental health issues, or potentially it's more of a post-traumatic response, like being sick with a deadly disease in the middle of a pandemic. Are we prepared as a healthcare workforce to essentially talk about these side effects in the language of trauma?
I don't believe that we are. And I think that's going to be the role of groups like the Behavioral Health and Wellness Program and others out there to educate providers on mental health concerns. Because I don't think they're going to have their hands full, and they're probably going to do what they normally do and get as many people vaccinated as fast as possible. I could be wrong, but I will be surprised if they are prepared for that, Jim. Okay. I think we're going to have to do a lot of work in that area.
Well, not the answer I hoped for, but definitely the answer I expected.
Yeah, unfortunately.
All right, we are at 1 minute till time, and nobody chimed in while I was asking my diversionary questions. So thank you so much again, Kathy. That was deeply, deeply informative. We'll send an email out to everybody so you can see where the webinars and slide decks are. And otherwise, please reach out to BHWP if you have further questions. We'll be following this closely, at least for the next year, maybe 2 years or longer.